Hello, everyone, and welcome back to the podcast. I know that has been quite some time that I have done the last one. But today I want to talk about something that is often clinically underestimated in older adults living with frailty, and that is constipation. But this episode is not really about constipation alone. It is about how frailty changes the way deterioration presents. How relatively small stressors can trigger multi-system decline. And how what initially appears to be infection, functional deterioration, delirium, or general decline may actually require a completely different clinical interpretation. So recently I presented a poster that I'm sharing in this podcast. And if you want to look more in detail, I will put all the information in my captions of the podcast, so you can go there and have a look, and you can send me any questions you have about it as well. More than happy to discuss and respond. So the title of the poster is Missed in Plain Sight: Constipation as a Reversible Driver of Acute Deterioration in Frailty. And developing that work reinforced something important for me as a frailty practitioner and ACP trainee, that frailty requires a distinct clinical lens, because older adults living with frailty rarely will present in a very neat textbook ways. So when we talk about frailty, we are not simply talking about aging, isn't it? Frailty reflects reduced physiological reserve and increased vulnerability to stressors. This means that relatively small triggers or insults can trigger disproportionate deterioration. And importantly, deterioration in frailty is often atypical and multi-system, fluctuating, and clinical complex. It's all about complexity in frailty, isn't it? And in younger adults, constipation may primarily present as about symptoms, and normally is a very straightforward, can be a very straightforward presentation and resolution. But in frailty, constipation may instead present through delirium, falls, immobility, urinary retention, reduced oral intake, dehydration, acute kidney injury, or sudden functional decline. And this is where recognition becomes difficult, because if clinicians are primarily looking for disease-specific presentations, reversible contributors may remain hidden within the wider clinical picture. The poster was inspired by a clinical case involving a very frail older adult who presented with acute deterioration. The presentation initially appeared to fit a common acute pathway: confusion, raised inflammatory markers, reduced mobility, urinary symptoms, functional decline. Naturally, infection became the initial clinical focus. And that is understandable. In acute care environments, we are trained to rapidly identify high-risk pathology and follow disease-focused pathways. However, despite treatment, the clinical trajectory did not completely align with the original assumption. Deterioration continued, symptoms didn't improve. And this is where reassessment became crucial. Using a frailty-informed comprehensive geriatric assessment approach, like using a CGA tool, the picture began to change. Constipation and fecal loading emerged as a clinically significant contributors within a much wider multi-system presentation. And importantly, once recognized and treated, the symptoms improved as well. The delirium improved, the urinary retention was reversed, and the functional status started to improve as well. One of the most interesting aspects of this case for me was not only the constipation itself, but why it was initially missed. And I think this reflects a much broader challenge within frailty care, that is the diagnostic anchoring. Once a particular diagnosis becomes dominant, especially infection in acute care, it can shape the entire interpretation of the patient. And if you start to think about it, this happens a lot in our practice in very different presentations and in so many things, because you are trained and to look what is dominant. And then the diagnostic anchoring happens. But in frailty, you have to be very careful with that, because frailty often does not follow predictable single disease patterns. Delirium may be the presenting symptom. Falls may be the presenting symptom. Functional decline may be the presenting symptom. The underlying driver may sit underneath all of this. And this is why frailty challenges us to move beyond isolate organ-based thinking. Sometimes the issue is not a single disease process in isolation, but an interaction between vulnerabilities and stressors occurring at the same time. What fascinates me while developing the conceptual model, that was a nightmare to do, but very interesting, because I really love conceptual models, because help me put in a visual way my thinking, and I really need to like writing or visually see how things are related. So developing this conceptual model for the poster was how interconnected these symptoms actually are. Constipation is not simply a bowel problem. In frailty, it may interact with cognition, with hydration, with mobility, with bladder function, with medication burden, with nutrition, and overall physiological reserve. So the poster conceptualized constipation as a reversible stressor, contributing to a cumulative and bidirectional deterioration across multiple systems. And I think that systems-based perspective is extremely important, because in acute care we often separate problems into categories, isn't it? Falls, delirium, AKI, retention, immobility. But in frailty, these problems normally coexist and interact. The boundaries between them are rarely clear. And I think there are several important implications from this. Firstly, reassessment is very important in frailty. If the clinical trajectory does not align with the original diagnosis, we need to pause and reconsider the wider picture. And in frailty, the big picture is very important to have in mind all the time. Secondly, comprehensive geriatric assessment, the CGA tool, is not simply a checklist. It is a way of thinking, a structured approach to understanding interacting vulnerabilities more than isolated disease processes. And thirdly, early recognition of reversible contributors is really important too. because if we delay recognition, that can contribute to avoidable harm, prolonged delirium, deconditioning, loss of independence, and unnecessary hospitalization. As an ACP trainee working within frailty, one thing that increasingly stands out to me is how important clinical reasoning becomes in these situations. Not simply identifying pathology, but interpreting complexity. Frailty often requires longitudinal thinking, pattern recognition, tolerance of uncertainty. That is so difficult for us clinicians. But in frailty, you have to have tolerance for uncertainty, repeated reassessment, and because a lot of times is a trial and error in frailty as well, even in terms of treatment choices. We have to reassess, and reassess because the treatment approach normally is different from younger adults as well. And the integration of multiple small clinical clues. Sometimes the key intervention is not discovering completely new information. It's more about reframing the information that is already there. And that became one of the central reflections from this work. Recognition emerged not from dramatic new findings, but from cognitive reframing using a frailty-informed clinical lens. So I think the biggest message I want to leave today is that frailty changed the meaning of deterioration. And if we continue interpreting older adults only through disease-focused frameworks, we risk missing reversible contributors hidden within complex multi-system presentations. Constipation may appear simple and can be, but in frailty, even minor stressors can trigger profound deterioration. And sometimes the most important clinical question is not what disease does this person have, but what reversible stressors are overwhelming this person reserve. And I think it is this. I hope you enjoy. If you have any questions, please feel free to contact me and to discuss. I love to discuss this topic. Thank you very much for listening. And if this episode resonates with your own experience in frailty, geriatrics, acute medicine, or advanced clinical practice, I would really love to continue the discussion. Thank you and see you next time.